Hi, thanks for joining us. Our next presentation is going to be Understanding Anxiety and Challenging Behaviors in Angelman Syndrome. Our presenter, for many of us, needs no introduction. She has so generously donated her time and knowledge to the community in many ways, and especially through social media forums. This is Kate Ahern. Kate completed her undergraduate and master's degree at Simmons College in Boston. She taught in special education, primary public education settings in Massachusetts for 15 years. She currently works as an assistive technology specialist and special education consultant for Easter Seals, Massachusetts, and is in private practice now. She is interested in augmentative and alternative communication as it applies to children with complex communication needs, particularly Rett syndrome and Angelman syndrome and other genetic neurodevelopmental disorders causing dyspraxia and apraxia. So thank you so much.
Thank you. Hi, everybody. Is that working? All right, fantastic. We've successfully imported 28 out of 28 slides. So I don't know if you all caught the technology drama happening up here this morning, but since 6 a.m., I've been trying to get this presentation into what is called Pear Deck, which will allow you all to interact with the presentation as I give it. And at the last possible second, my tablet decided it was not going to connect to the projector. So I stole Siobhan's laptop, and apparently it looks like it's working. So everybody do this with me. This is what assistive technologists do, because we believe in magical things. Cross your fingers and repeat after me. Technology, technology. Technology, technology. Please, please work. All right, let's see what happens. Oh, I think we're there. So, for those of you who have a computer or a mobile device, if you go to the website peardeck.com/join, and you enter this code, GXKAS, they give you a nice acronym for it. Green X-rays keep acidic submarines. And as you log on, once I see a couple of you have gotten on, I'll start the presentation, and that way I'll be able to ask quick questions and get your participation so I know that I'm meeting your needs. And one of you have joined. So whoever you are, good job. Well done. 6. All right, that's exciting. I'm going to leave the code up for another minute or so. All right, if you're still trying to get on, write the code down because I'm going to change the slide. GXKAS. All right. Not my computer. The buttons don't work the same way. All right. So today we're going to talk about anxiety and challenging behaviors in Angelman syndrome. So let's try a question. All right. So let's see how many of you have a child who has Angelman and anxiety. You can raise your hand. You can do it up on the screen. Oh, it looks like 3 of you got the kids who don't have anxiety. And I'm going to guess they're under 5 years old. So you may not have seen the anxiety yet. But it looks like anxiety is a pretty significant issue here. So one of the things that we think about with anxiety and Angelman, at least for me, the first thing I think about is the eye contact. So I'm sure you've all noticed that your child with Angelman syndrome really seeks out eye contact from you. And the reason that they do that is it provides a child with a secure base. So this is actually an instinct that starts in infancy, which is as an infant starts to explore their world, they go back to the parent for eye contact and interaction, which calms them and allows them to feel safe to explore the world. In Angelman syndrome, that reflex sticks around, and frankly, it sticks around for all of us too, right? I mean, when was the last time you were really, really sick or whatever, and you thought, I want my mom, right? It doesn't totally go away in any of us. So for our kids with Angelman, they're looking for eye contact and reassurance because they're having this anxiety issues, and we don't even know it. We just think they're looking at us because they love us. And they do, but a lot of it is returning to this secure base. How many of you have a child whose hair, I'll make it a question on the screen. How many of you have a child who will either pull your hair or pull your head to get your eyes closer to their eyes? Okay, how many of you knew that's what they were doing? Okay, they're pulling your hair in your head because they need that eye contact, that reassurance, that secure base. So one of the biggest interventions that I know of that can work for this hair pulling issue when it's about eye contact, it isn't always about eye contact, but when it is about eye contact, is simply give the child another way to get eye contact. And if your child has a communication system, a button that says, look at me, does the trick. And you start by simply having on their device the look at me button, and you have their device and you press look at me and have everybody in your house look at you. And you all take turns pressing look at me and then looking at them. So that everybody's able to see this is what happens. If I press look at me, everybody looks. And then hopefully over time, the child will understand, I can say look at me and get that eye contact. I don't need to pull hair. I mention this mom every time, and she usually ends up being in the room, but it's the mom who has a look at me button and it stopped hair pulling in the car. Is she here today? No? So a couple years ago, I mentioned to a mom that she said that she was having trouble with her daughter in the car, and the only time she was really pulling hair was when they were in the car. So what she did was she added a look at me button, and she modeled it specifically for use in the car, and it eliminated the hair pulling behavior in the car. So the child was able to say, look at me. Mom would make eye contact through the rearview mirror, and the child would be okay. And it might happen 50 times in a drive, but it wasn't the driver getting her hair pulled. So that can be a big thing. And so if we always come back to this idea that when in doubt, after we've ruled out medical reasons, when in doubt, rule anxiety out. All right, there's a good chance that if you're seeing difficult behaviors, that they're anxiety-based. So when in doubt, rule anxiety out. And there are other reasons, of course, for behaviors that can be challenging, but anxiety is a huge one. One of the things to think about, or that I think about, is the still face study. How many of you have heard of the still face study? So a few. So this is usually taught in like developmental psych classes. It was first done in 1978. It's been repeated many, 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 many times. And what the still face study does is it looked at what a baby would do if a mom played with that baby very interactively, mirrored the baby's feelings, and then for 3 minutes, and then gave a still face. So, right, so like you're resting, still face without any affect. And what it turns out the child will do is they'll attempt to regain that connection. They want that secure base back. So they will try to charm their mothers. They'll reach out, they'll make noises, they'll blow raspberries, they'll wiggle their foot. Whatever interactions have worked in the past, they'll try. And then if that doesn't work, they'll try crying, screaming. And then eventually, if they don't get that connection reestablished, they may try to self-soothe, which in an infant looks like things like chewing on their hands, rocking, things that later, if you're older, get called stereotypes. Or they might become angry, upset. Some of the infants would hit their head on their crib if left in the still face study for a little bit longer. Some learned helplessness can kick in and they stop trying to interact. And I think what happens, or what I've seen happen in Angelman syndrome, is kids with Angelman syndrome still react to a still face the way an infant does. So they escalate their attempts to reestablish connection. I see this a lot with phones. Right? So mom or dad or a caretaker, a teacher, a babysitter, whoever, has their phone out and doesn't react to the child. And the child escalates their attempts at getting a connection. So they start making some noises, they maybe press some buttons on their device. When that fails, they throw things, or they pull hair, or they hit. Just last night coming in, I was talking to a family, and the child, so two different families. The first family I was talking with, the child was in a stroller, and when I started talking to her parents and not paying attention to the child, she immediately tried to re-engage by pointing at the escalator and pointing at the Christmas tree, right? So perfectly good social attempts to get interaction. The next child I ran into, I said hello, I got a hug, and then I started talking to the mom, and the child hit me, right? Now, what better way to either get my attention or to make it clear to mom, you need to interact with me, not with her. So then the question becomes, what are we going to do about it? Because as much as we would like to give attention every single second of every single day, that's not humanly possible, right? So the first thing that we do is we look at when is anxiety likely to strike. And it comes down to 4 major times, all right? So one of them is there are new, different, or increased social demands. Another one is that there are unpredictable situations. Another one is there's a change in a routine or there's a transition. So I ran into a family yesterday, and I jokingly said that at the moment my presentation about anxiety was going to be about flying in an aluminum tube for 2.5 hours. And then they told us that their daughter loved to fly, but that she doesn't like boarding or when people start getting off the plane. And what are those examples of? Transitions, right? So when things are static, when things are the same, she enjoys flying. But during the transitions of boarding and getting off the plane, she doesn't enjoy it. Anxiety increases. And new, different, or unfamiliar people or environments. So just now at breakfast, I love that all of my examples happened in the past 12 hours. Just now at breakfast, I was eating with the grandmother of a child who has AS, and she was telling me that they had a family birthday party, and the girl with AS's cousin had friends over, and the friend entered the room, and the girl with AS hit her. And immediately I went back to this checklist, and what do we have? We have a new person, right? So we can go right down that anxiety checklist and look a lot of the time and find the thing that is likely a trigger. Is there something new or different or an increased social demand, right? So when you have the speech therapist or the ABA person pushing your child to do something social, to interact with somebody and have a social exchange, and the behavior increases, that's an anxiety trigger. When you get a note home that says he was fine until we tried to take him to the nurse's office because he had a cut on his finger, right? Anxiety trigger, unpredictable situation, wasn't part of the routine. Or they're fine until the morning aide leaves and the afternoon aide arrives, right? I got a lot of head nods on that one, right? So that's a change in routine. It's a transition. They're fine within their normal routine, but if there's a substitute bus driver, it's all over, right? So that's a new person or environment. So if you look through your child's day and when you see these things, you'll probably find out that the anxiety triggers are there for a lot of the problems that you have. So again, what are we going to do about it? There should have been another, the slides are out of order, but we're just going to go with it, right? Because we don't have a problem with unpredictable situations. So some of the behaviors that we see are the hair pulling that we already talked about. Sometimes we see some biting, throwing objects, disregarding safety, so going into the street, touching a stove, going near unenclosed water that they shouldn't be near, sleep-related behaviors, sensory issues, so things around touch and need for deep pressure, water seeking, mouthing objects, what people love to call non-compliance, which is you didn't do what I told you to do. Dropping to the floor, what I like to call pulling a Gandhi. Food-related behaviors, and we know a significant subportion of kids with Angelman syndrome have these food-related behaviors. They have an insatiable appetite, and all they think about is food. And I can't imagine how difficult that must be to eat, and then 10 minutes later, your brain has no idea that you ate, right? And you just want to eat again. Pushing people and items, and then other anxiety-related behaviors. So by those, I mean the things you'd see in us. Fingernail chewing, grinding teeth, hyperventilating, refusing to move, fight or flight instinct, right? All anxiety-related sort of behaviors. So then if we think about, well, why? What's going on here? So hair pulling, from what I've seen in kids with AS, is almost always to pull somebody closer. Which if you think of that poor kid, right? So they've got this idea that I need to get this need for a secure base met. I need eye contact, I need connection, and then they do it in the worst possible way. They pull your hair, which gets your face closer, but hurts, so you pull away and you're upset. So you're kind of stuck in a bind there where the child is sort of getting their needs met, but not really. Biting can be to refuse, to protest, it can be sensory, it can be anxiety, it can simply be look at me. A lot of these behaviors boil down to look at me. Throwing things, all the same sorts of reasons. Disregarding safety, I think on that one, it has a lot more to do with just not understanding safety risks, but also not being taught safety risks. We don't spend the time sitting down and teaching all of the don't go near the street, don't go near the stove. I've done a lot of work with some kids around what we're allowed to touch in the kitchen and writing stories about it and making videos about it so that she can be in the kitchen and we don't have to worry as much about her touching the stove or a knife or something. Sleep-related behaviors, I'm not even going to go there. You guys have lots of specialists to work with you on that. But we all know that lack of sleep increases anxiety. So then you're in this vicious circle, right? And not just the kid's anxiety, right? When you haven't slept, your anxiety and your depression also increases. And then you sort of have this perfect storm. You have a tired and anxious and cranky kid and a tired and anxious and cranky parent. And then you're all just in this spiral of being anxious and cranky to each other. So if you can take care of those sleep behaviors in any way, you should try to do it. And like I said, there's specialists far more qualified than I am working on sleep issues. Toileting-related behaviors, I think for a lot of kids who have had chronic constipation, which is a lot of our kids, the idea of going to the bathroom brings back memories of pain. So it's very angst-provoking. It makes you anxious to think about going in and trying to use the toilet because it might hurt. So really thinking about, this toileting-related behavior, is it about past pain or current pain and anxiety about that pain? And then sensory issues obviously are neurological, and they come from the need for sensory input. Water seeking tends to be neurological. It's part of Angelman syndrome. Mouthing objects can be sensory. It can be anxiety provoking. I see fingers in the mouth and pens in the mouth as I look at the crowd here. So we're not the kids aren't the only ones who mouth objects. It's just we pick the socially acceptable ones. We're not mouthing somebody else's shirt, for example, while they're wearing it. I always call that DNA samples. Thank you for the DNA sample. Dropping to the floor. So the easiest way to not go someplace that makes you anxious is to drop to the floor and not go there, right? So if you're on the floor, you're not going to the place that was giving you an anxiety attack. Now again, that's not the only reason a kid might drop to the floor. It could be about power. But again, why would a kid seek power that way? Because they want control. Why would they want control? Well, so on some level, they feel out of control. So we're back into that spiral of anxiety issues. The food-related stuff, again, it could be neurological. It could be boredom. I mean, I don't know how many kids I work with I have some who it's clearly neurological, and then I have some who asking for food is a good way to get something to happen. They're bored, let me ask for a snack, somebody will make it for me, it gets some activity. It can also be medication related. If you have a child who's on an atypical antipsychotic like Seroquel or Zyprexa, you can see these, this sort of carb vacuum behaviors. Pushing people and items can be to refuse, it can be anxiety. And then any time you don't see a clear cause of anxiety, you should be thinking about, could this be anxiety? So what can we do? So first of all, we take care of our basic daily healthy habits. We have appropriate nutrition. A child who's had 4 ho-hos and a yoo-hoo maybe isn't going to have as easy a time keeping their anxiety in check as a child who's had a healthy meal over the course of the day. We're going to make sure we have exercise and movement and activity happening. A lot of our kids have attentional issues, and we know that exercise helps with that. A lot of our kids have sleep issues, and we know that exercise helps with that. So we're going to make sure that movement is happening. I run Angelman syndrome communication groups, and one of my big tricks is to get the kids to help me pass things out when it looks like they need to move. But the tip is when you do that, you have to put something in each hand. Because if they have one hand free, they're going to pull hair with it. So you have a glue stick in each hand. So go bring these 2 glue sticks to so-and-so. And then sit down. So you're not pulling hair going back. Getting enough sleep. Looking at pain issues. The first thing to rule out whenever there's some sort of change in behavior or increase in behavior is pain. If you're seeing an increase in hands in the mouth, it could be anxiety. But before you go down that path, make sure that it's not a toothache or jaw pain or strep throat or postnasal drip or any of the reasons that a kid might put their hands in their mouth. When I was a new teacher, I worked with a child who would take his whole hand and insert it all the way back in his throat. And it wasn't a child with AS, it was actually a child who had Down syndrome and autism. And he did this until he gagged. And we tried all sorts of behavioral interventions. What worked was they treated his allergies. And all of a sudden the behavior was gone because it was from postnasal drip. And so no matter what I could have done behaviorally to work with him or what communication I gave him, Until the medical issue was dealt with, I doubt the behavior would have changed. And then, being sure that we meet sensory needs. So in people who have low tone, and this goes for Angelman, but also for Down syndrome and cerebral palsy, and any condition where there's low muscle tone or even mixed tone, but low tone in the trunk, deep pressure can be really soothing. When you have low tone, you're not getting as much input from your body. So deep pressure can really help center and ground a person. So weighted blankets, weighted wraps, some of the crashing we see kids do. They fall on the couch really hard. They bump into the walls a lot. They're getting that sensory input met. So making sure we're meeting that. And then also remembering the super sensitive hearing that we have in Angelman. And I don't think this is studied well enough. But how many of you have noticed that your child can hear your neighbor 3 doors away? Come outside, get the mail, and go back inside? Yeah. It does seem to be some hyperacoustic, so highly sensitive hearing in Angelman. And what we know from verbal kids with hyperacoustic hearing, kids with autism or kids with Williams syndrome, what they tell us is it can be very painful. And it can also be very confusing and very distracting. And what I know from my kids with AS is if I don't acknowledge that they've heard something, they can't move on. So I have to say, oh yes, I heard a door too. It's just the neighbor. How about we get back to what we were doing? And then we're okay. But if I ignore it, then they're like, you idiot, didn't you hear that sound? And I still ignore it. They're like, yo, there was a noise, wake up. So acknowledge it, and then you can move on. Another thing you can do to help with behavior is ensure that those who interact with your child are respectful and understanding. So how many of you have had a problem at school with your child, and it turned out that the problem at school was because somebody was, please draw on the grid. That's not what I want. Here we go. How many of you have had a problem at school and it turns out that the problem was somebody wasn't treating your child respectfully? Right? So it was, instead of asking your child to come with them to the bathroom, they were dragging them there. Or they were yelling at them all the time. Or they were telling them to stop it without understanding why they were doing it in the first place. So we can see that about half of you, a little more than half, have that problem where if your child's not being treated respectfully, we see the acting out behaviors or we see the anxiety-based behaviors. Now I'm going to ask this question again, but about yourselves. So how many of you yourself are less than pleasant when you've been treated poorly or without respect? Oh, somebody's pleasant all the time. I want to be that person's friend, no matter how rude you are. So it seems to be fairly universal that when people are treated with disrespect, they don't act back in a kind way all the time. And that's true for our kids with Angelman too. They get it. They may not understand every word that's being said to them, not necessarily because they don't have language, but because we talk too fast and we don't give enough processing time. And but they know when they're being treated with disrespect or when they're being disregarded, and that can, make them angry. And then they have good reason to not necessarily, participate the way we want them to. So what can we do? One of the things we can do is we can analyze patterns and triggers of anxiety and calmness. And you want to not just look for when your child is anxious, but look for when your child is calm, right? Those calm times are the antidote to the anxious times. So if you know the situations in which your child is completely relaxed, you can start to pull aspects of that into times when they're not completely relaxed. Looking at where's the line between affection and aggression for your child. I work with Siobhan's daughter, Samantha, and she'll be presenting with me the next part 2 of this session. And one of the things that we had to really work on with her was safe hands when you hug. Because she'd be hugging you and it was perfectly fine, and then she was ripping your hair out. Right? So we really had to work on teaching her to have safe hands when she was hugging somebody. It's not perfect, but we've come a long way, I would say, with the safe hands when you hug. Her babysitter actually taught her to do waist hugs. So kids with AS, they want to hug your head because they know you live in there. That's where your eyeballs are. That's where you live. You're in your head. So they want to hug your head and get it nice and close to them for that secure base. Her babysitter, and this is not a behavior that transferred to anybody else, but her babysitter taught her to hug waist so she doesn't get the head hugs or the hair pulling that goes with that. So looking at those patterns and then teaching a cue for safe or gentle or calm hands or calm body. You don't want to teach this while the anxiety or aggression is happening. You want to teach it while things are nice and calm and make it a game. So if you wait to say to your kid, gentle hands when they're in the middle of smacking you in the face, not a highly effective teaching procedure, right? But if you work on safe hands, which Samantha does safe hands like this, I have another kid who crosses their hands, I have one who folds them on the table, whatever's going to work for your kid. But if you work on learning that command ahead of time, then you can use it when you need it later. And to teach it, all you need to do is say, oh, let's play the safe hands game. I have safe hands. Safe hands, yay, mommy. Mommy has safe hands. Can you have safe hands? Oh, yay, you have safe hands. You do that a few times over a few weeks. Eventually, the idea that having safe hands, however you want to do your safe hands, leads to a big payback, lots of eye contact, lots of social reinforcement. And now you have that tool when they're going for your hair where you can say, safe hands, and they can go, yay, safe hands, and you don't have a bald spot, right? Another thing you can do to teach that is write a social story about safe hands. And I'm going to talk about social stories in a minute, although I better start talking much faster. Using visual supports. So visual supports work for everyone. How many of you stick a Post-it somewhere to remind you of something? That's a visual support, right? You put a note on your phone, visual support. You put something by your car keys to remember to take it with you tomorrow, visual support. So use visual supports for our kids. Using routines and visual schedules. Now, remember, if we go back to our anxiety triggers, one of them was a change in routine or unpredictable times. So a visual schedule can help deal with that. And if you don't have time for a visual schedule, you can do it auditorily and simply say, okay, here's what we're going to do. We're at this store and you're getting anxious and I'm getting scared. So let me give you the routine. We're at this store. We're going to walk to the car. We're going to get in, put on our seat belts, drive home, and have a treat. Listen again. Walk to the car, put on your seat belt, drive home, have a treat. And then you just keep repeating it nice and slowly so that they have the routine. Now they feel calmer and safer. They know what's going to happen. You want to be teaching emotion identification and giving them that vocabulary. And you're going to be using social stories and video modeling. Hopefully I'll get to that. What time does this session end? 2:00. Just keep going. When Colin Firth gets here, you're done. What time? What? Colin, Colin Farrell? Okay. Colin Farrell. I don't have a TV. It causes anxiety in my life. I threw it away on September 11th. Worked for me. What time? Oh, so we have 15 minutes? Oh, we can do this, can't we? All right, here we go. So we're going to analyze and identify patterns. So you're going to take notes, photos, and videos so that you can keep track of what it looks like when they're calm and what it looks like when they're not calm. Now, I know you probably hear this from your ABA folks, and the only reason I mention it is because it works. You're going to keep an ABC chart. I'll show you a picture in a minute. If possible, if the behaviors are significant, ask for a functional behavior analysis at school. They call it an FBA, when they start throwing the acronyms at you. They're going to do an FBA to make your PBIS, your positive behavior and instructional support plan. But somebody can come in and analyze the behavior for you. There are lots of data collection apps that you can use to try to keep track of when you're having problems. I could put some of them on my website for you if you want. So, using an ABC chart. So, in an ABC chart, you're just going to make 3 columns on a piece of paper. The first column is the antecedent. That's what happened before the behavior that you're finding troublesome or that you're finding awesome. I mean, you could use this to reinforce awesome behaviors as well. And then the behavior. So, a behavior is measurable and observable and not physiological, right? So it's not anything that has to do with neurology. It's not a seizure. It's not stereotypies that are neurologically built in. And then the consequence, what happened after the behavior. So an example of this would be the caregiver touches her purse or her keys. The child throws a nearby item and looks at the caregiver. How many of you have had this happen? Right? You touch your keys, you touch your purse, and then you get a behavior. That's because our kids are really, really good at understanding social rules. So they know if you touch your purse or keys, there's a good chance you're going to leave. If I touch my bag before it's time for me to leave and I don't leave, a lot of my clients have a really hard time. Right? I have one client where I've been working with him since he was 3, he's 7 now. I no longer bring anything into the session because when I arrive, he pats me down for technology. And if I were to accidentally touch my bag during the session is now over. Right? So sort of for me, I know those are antecedents. So I avoid them. And then the consequence of the child throwing the item is the caregiver scolds and makes, oh, don't throw that, and makes eye contact, which of course has now provided a secure base. So the child's need has been met. Now the temptation is always to stop giving the reinforcement, right? So any behavior analyst will come in and say, well, don't make eye contact with them and the behavior will go away. But what we know in our kids with AS is if we stop making eye contact, and that's the secure base, we're increasing anxiety and setting ourselves up for a whole day of behavior, right? And they'll say, oh, that's an extinction burst, that'll go away. An extinction burst is, have you ever gotten on an elevator and pressed the button and nothing happens? Anyone? Yeah? So what do you do when that happens? You press it again. And again, and again, and again, and then eventually you get out and try a different elevator, right? That pressing, that's an extinction burst. And yes, technically, you could withhold eye contact for all of these behaviors, and eventually the child would stop doing that behavior. My question is, then what's the long-term consequence of that? Your child is doing that to get a secure base, to have a safe connection, to go out and explore the world. If you don't provide that, what happens? So instead of changing how we reinforce, I'd like to think about what are the things we can do in the A column and the B column. All right, so in Angelman, we have to dig deep. We have to look for the anxiety and understand the need to avoid or escape the anxiety. And the fastest escape for a lot of our kids is that eye contact. So when we look at that ABC chart, under A, we look, was there an anxiety trigger? And we go back to that list. Was there a new person or a new environment? Was there something unpredictable? Was there, the other two things that aren't coming to my head right now because I'm trying to go fast. So once we're doing this ABC chart, when we're looking at the antecedent or what happens before, how we can change it is we can either prevent the antecedent, right? So if we know the antecedent is touching our car keys, we can make sure we don't pick up our car keys until we're actually ready to go. We can pre-teach. We can write a story about sometimes mom has to move her keys. We can write a story that says, when I have a question about if mom is leaving, I can use my talker to say, are you going? And we can practice. We can do little skits where we each take a turn picking up the keys and then asking, are you leaving? And at first having the answer be no, because that feels a lot safer. And then having the answer be yes and practicing what to do if the answer is yes. So we can move our focus from here, where everybody's going to tell you to ignore, and that might have long-term consequences, over to here, where we prevent, we pre-teach, and we practice. At the same time, we're going to look at that behavior and replacing the behavior, right? So if the behavior is throwing something or pulling your hair, what can we teach them to do that's a more effective way to get that need met? So an example is giving a button that says, look at me, or teaching a hug that's around the waist instead of around the neck, right? So looking at what are they trying to say with that behavior, and what would be a more effective way to do that? If it's a behavior around the toilet and constipation causing pain, you can have a social story over here in the prevent, pre-teach, and practice that says, sometimes it hurts when I poop. A gross social story, but facts are facts. Sometimes it hurts when it poops, but I'll be okay. And then you can have a button on their talker that says, I'm afraid it's going to hurt. And then you can provide lots of arms reach away, eye contact, and reassurance so that they'll be able to go through that process. And then every time they go through that process and they don't pull hair or throw things, you can have a giant party. Right? Until eventually they get the idea that, I'll probably be okay. So what I'm asking you all to do when you go back and you meet with your ABA specialists who tell you to ignore is for you to tell them about these other tools that you could try, right? Because truth be told, you parents are the ones who have to end up doing the work, right? How many of you have had to train your team and a year later train the next team and then train the next team? Yeah, it falls on you. We're sorry. I'm very ashamed of my field about this fact, but it is how it is. So this hopefully can help you help them understand that there's some other ways to do this. So to eliminate a negative behavior, we must replace it with a more efficient positive behavior. Okay, you can't take something away without giving something in its place. Right? That's why people who are quitting smoking might suck on lollipops, right? And they might have a nicotine patch. They might have 15 different things that are replacing the behavior. Because the best way to do it is to replace that behavior. That's why they tell you when you're losing weight to put the carrot sticks in the front of your fridge so they're the easiest thing to grab. So you can push them aside and reach back. Clearly, this is not a behavior I've mastered, but you get the idea. You have to replace the behavior with something more efficient. So this is where you all have to be clever enough to come up with something more efficient and then teach it. So I've already talked about this, but when we talk about ignoring, just remembering that it may not work well. It will work if you do it and you ignore long enough. One of the problems that I see is people decide to start ignoring it like at the worst possible time. Like you're reinforcing it most of the time, but then you go to the movies and you start ignoring it. Because that's where you want the extinction burst to happen, right? At the movies, at the restaurant. Yeah, so just be careful with the ignoring and know that, if you do those other things, you pre-teach and you provide a replacement behavior, hopefully you're not going to need to use ignoring that much. I have this picture of Jessica here to remind me to tell a story about how I work with Jessica and a couple of the kids in our groups. So Jessica is, she's got some anxiety issues, but she's also likes power, right? She likes to be the boss. And when we have our Angelman syndrome groups, she will sort of pull out all the stops, right? So she'll sit on the floor, she'll get out of her seat. So my standard way of working with Jessica is to applaud every kid who's doing the correct thing, right? So Jessica's out of her seat and laying on the floor, and then I clap for everybody else. Samantha is sitting in a chair. Well, Owen is sitting in a chair. Allie is sitting in a chair. Jalen is sitting in a chair. And by the time I go through all the kids, Jessica's back in the chair. Right? And so, Jessica's sitting in a chair. And that really works for her. Now, in the long run, if I saw her more than once a month at group, I would want to have a social story about staying with the group. I would want to give her some tools on her talker to say, I want attention, I want people to clap for me, those sorts of things. But in the short term, that fix works. I tried it on another little guy. He had thrown his talker, so I cheered for everybody whose talker was on the table. But the poor little guy, he couldn't get off his chair by himself. So he's sort of hanging off the chair, reaching for the talker. Like, I want to pick up my talker so you can clap for me, but I just can't reach it. But so I was able to scoop him off his chair, and he got his talker and picked it up. And that can work in your house, too. You can cheer for everybody who's eating their dinner. You can cheer for everybody who's having safe hands. And offer that sort of reinforcement to everybody else. So it's ignoring, but it's not ignoring, right? Because it's teaching them an alternative behavior. All right, so visual supports. So these are specific reminders that you can have around your home to remind you of things. It's not enough to hang it on the wall. You have to teach it and then reinforce it. So like hands in the car, right? How many of you have a kid who not so fond of the hands in? Yeah? I have a kiddo who tossed his talker out of the van while it was moving. It died. I mean, he didn't need it anymore because it was dead. Seems logical to me. But you can have reminders around this, but pre-teach it. Have a story about it, talk about it, that you got to have your hands in when you're in the car, you got to be safe. And then when they are safe and keep their hands in, make a big deal out of it, lots of social praise. These can be used at school. They can be used anywhere. And what's nice is lots of times they're transferable. So if they're working at home, they may work at school and so on and so forth. There are 9 reasons to use visuals, but we're in a hurry. Sorry. Utilize routine. So this is the idea that...
So we're going to go a little over since we had technical difficulties, so you have more...
2.5 seconds.
Like another 10 minutes.
10 minutes? Okay.
Is that too little?
I'm teasing. So utilizing routine. So if you have established routines, you do things in the same order every day, then your child has a predictable thing to follow. So I heard this story secondhand from Paula Evans through Siobhan, but it turns out that Paula's daughter Ainsley would give them a hard time brushing her teeth. And then they went to school and they said, well, we're having a hard time brushing her teeth. And the teacher said, well, I don't know why, because she does it alone. Here, watch. Ainsley, it's hygiene time. And she got her hygiene box, went in the bathroom, brushed her teeth, right? Because there had been an established routine. So we need to use those routines to our advantage, okay? But one of the things to remember is it's not a routine unless there's something telling the child that the routine is starting. Okay, you can't let them guess. You need to specifically say, preferably with their talker if you have one, but with pictures if you don't, we're starting our bedtime routine. We're going to take a bath, brush our teeth, put on pajamas, read a story, go to bed. And go through that routine every day. And hopefully, eventually, it will become something they can do more independently. We actually had the same experience with Samantha at her IEP recently, where they said, well, she's mastered the deodorant goal. And we were like, she has? They were like, yeah, she can take the cover off, put on the deodorant, switch hands, put it in the other armpit, put the cover back on. Really? Okay. Guess we won't be doing that for her anymore. But building those routines is what allows them to feel safe and secure. I have a little girl I work with. She has Rett syndrome, actually, but she would freak out getting in the car any place other than to school and to home. We were able to fix it simply by showing her and her talker where she was going. Even if she had been told verbally it wasn't enough, she needed to see it. So if on her talker we said to her, we're going to the mall, she'd be fine. But if we verbally said, we're going to go to the mall, and got in the car, she'd freak out. So really thinking about what combination does your child need? Do they need the visual plus the verbal? Do they need a strict routine? What will work for them to keep them going? Using visual schedules so that your child knows what's happening when, and how involved the schedule is depends on your child's needs. So it might just be what's happening now, what's happening later. It might be the whole day. It depends on your child's specific needs around schedules. Teaching emotional identification. So a lot of kids with intellectual disabilities and a lot of kids with other kinds of neurodevelopmental disabilities always say they're happy, right? How are you happy? Yet you're screaming. I'm happy. Okay. I had a child with Down syndrome who I only knew was angry if he started calling me the Kate, right? If he called me Kate, he was fine. If he called me the Kate, he was furious. If he was really furious, he would call me the Kate, the Power Rangers are going to get you. And then I'd be like, okay, it's going to be a tough day. But for him, it was he couldn't handle the idea that he was angry. So it came out in other ways. But we need to do specific work that teaches our kids to recognize in their bodies what's happy and what's anxious, what's angry. You know, I see your hands are up like this and you're laughing and smiling and you made a very happy noise. You feel happy. You know, I see you're grabbing your head and you won't look at anybody. You feel anxious. And then showing them those words on their talkers. Because you have to have that vocabulary expressively and receptively in order to talk about the emotions and deal with them in a way that is more productive. We also need to teach kids how to calm themselves down. And of course, this starts by teaching ourselves how to calm ourselves down, right? It's hard to teach somebody how to calm down when you're in a chokehold. But one of the things we can use is a talk aloud. So when we're in an anxious situation, we can talk it through with ourselves to teach the kids what a dialogue sounds like in your head, right? I'm stuck in traffic. I think we might be late. My body feels tight. I'm worried. I'm anxious. I need to take some deep breaths. I'm going to tell myself, it's okay. It's okay. And then your child gets to see you and learn from you. This is what you do when you're stressed out. Now, of course, if you're more the type of person to lay on the horn and start swearing, your child is now learning that's a good way to deal with being stressed out. So really think about what you're teaching in those moments. And then rehearse strategies when things are already calm. Again, don't wait until we're in full meltdown before you try to teach how to take deep breaths. It's really hard to learn how to take deep breaths, right? And the younger you are, and the more anxious you are, the harder it is. So when your child is calm, try to work with them to figure out what works and what they're capable of doing. Could they blow bubbles? Because you have to take deep breaths to blow bubbles. Can they blow raspberries? A little gross and spitty, but still accomplishes the deep breath, right? So what can you do to teach them those skills? I'm sorry I'm zooming through everything. Just want you to get everything. Offer lots of self-soothing choices. You know, what choices can you give them for when they're upset? And then teach them how to ask for it. So, you know, I had one child where we used to hang a sign if it was red, yellow, or green when you entered the house, because we would find out that when she was upset, everybody wanted to help, but then there'd be too many cooks in the kitchen. So if it was green, anybody could interact with her. If it was yellow, you could only interact with her if somebody tagged out. If it was red, you weren't even allowed to go in the room, right? Because if there were 5 people in there, you're just going to make her anxiety worse. But one of the things that we were able to do is to eventually teach her how to ask for things before it got that bad, before she got to a yellow or a red. To be able to say, I need to take a walk, leave me alone. Many, many years ago, I had a kiddo who had a button on his device that said, I'm upset because, and then the next page of things would say things that upset him. And it was usually, you won't let me do what I want. I'm upset because you won't let me do what I want. Give me some space and we will all be safe. And so we back up because he meant it. And usually he'd calm down. I had one teacher aide who was felt like that was giving in. So she'd get in his face when he said that. And he'd hit her and I'd be like, he told you. You should have moved. But, you know, teaching those skills. So social stories, this will be the last thing I talk about, and then I think we'll take a quick break before we start, whenever the next session starts. So social stories, there's lots of good research about them on there. If you Google social stories, you'll find lots of information. A social story, they were created by this woman, Carol Gray, back in the 90s or late 80s. So it's a story written in the first person perspective. It avoids any assumptions. It uses a patient and respectful tone. And it uses 2 kinds of sentences, descriptive and directive, right? So descriptive would be, my body feels very tight. My hands are in fists. And directive would be, I can sit down, or I can take a deep breath. You aim for 2 descriptive for every 1 directive sentence. All right, so it's a book more about, you know, teaching them how to recognize what's going on and then what to do with it, but it shouldn't be too bossy, is what I tell people. The perspective is always positive. You can do it, you can be safe, you can wait, the stories I've written of, you can wait, sometimes you have to wait to eat. I can be safe and walk to the bathroom. Getting out of the tub is okay. Lots of social stories along those lines with a very positive spin to them. And about half of them should celebrate strengths and successes and not just be about changing behavior. So some of them should be about things your kid already does well. You know, you can take off your socks, right? Written in a very positive way that's not directive, not to teach that, but just to celebrate the fact that they can do that. There's lots of info out there about it. I have lots of social stories I can share if you catch up with me at some time. I tend to use the app Pictello to write my social stories. So I have lots on all sorts of different topics. I have one called Safe Hands When You Hug that has a really cool picture of Darth Vader and R2-D2 hugging. Even Darth Vader has safe hands when he hugs. All right, and that is it for this first session. In the end of the next session, I'll have the links for the resources. So if you're not going to come to the next session, we'll get them to you somehow. If you Google my name, you'll probably just find it, though. So thank you all for coming. Have a good lunch. Somebody promised me hallelujahs and like amens, and they didn't happen. Amen. Thank you.
Hello? Okay. So, and just so you guys know, Kate is going to be on the Ask the Experts panel at 1:30 in the other conference room, so I'm sure people have follow-up questions, and that would be the time to ask them. Sorry to have to cut things short, but we do want to get you guys to lunch. Lunch ends at noon, so it's not very much time, but we will be starting right on time so that we can make sure we're closing on time and everyone can go get themselves done for tonight. All right, thank you.